tailored care management technical assistance initiative. So helping people in North Carolina in partnership with North Carolina Medicaid and the National Committee for Quality Assurance. Those of y'all that have quality measures, that's NCQA. Liz also provides quality improvement consultation on the COCM model, or the collaborative care model, and behavioral health integration in primary care to a statewide team of the North Carolina AHAC practice support coaches. Liz's clinical background includes trauma-informed care, integrated care models, grief counseling, hospice social worker, health equity, clinical supervision, and pediatric adolescent behavioral health. Liz joined the North Carolina AHAC in 2013 and has a bachelor's degree in psychology and a master's degree in social work from the University of North Carolina at Chapel Hill. And so if you'll hold on a minute and I'll introduce your partner. Chris Weathington serves as the Director of Practice Support at North Carolina AHAC with the mission to recruit, train, and retain the state's health workforce and help primary care and behavioral health practices thrive with value-based care. We just heard from Dr. Hobbs how the workforce is limited in North Carolina as in Arkansas. So Chris previously served in administrative leadership roles at UNC Health, NC Department of Health and Human Services, the North Carolina Office of Rural Health, and ECU Health. Chris is a graduate of UNC Grilling School of Public Health with a Master of Health Administration and a Bachelor of Science in Health Policy and Administration. So we're so glad to have y'all here. Thank you, and I know y'all are in store for a really good presentation here.
Thank you so much. Thank you. Can everybody hear me okay? The back? Thumbs up. Anybody in the back? Thank you. Well, hi, everybody. We are so excited to be here. This is my first time in Arkansas. We flew in last night. We actually left a rainy North Carolina to come to a sunny Arkansas. But I hear, had we been here 3 days sooner, it would have been opposite. So the fact that you all are here after a pretty massive weather event, you are here smiling, ready to learn. We are just excited to be with this group today. See if I can get this to work. I had it over here. Just hit it. That's what I do with all of our electronics at home. Let's see. There we go. All right, so we are going to continue the conversation today about the collaborative care model. We're going to talk a little bit about other behavioral health integration models, but mostly we're focusing on COCM. Again, I'm Liz Griffin. I am a licensed clinical social worker, and I hear we have some other social workers. So just show of hands, how many social workers, students, MSWs, LCSWs? Wow, yeah, social work. That's a lot of hands, y'all. Counselors, how many counselors do we have here? All right, counselors, a lot of y'all too. Any LCAS in the house? Any addiction specialists? How about LMFTs? We have any family and marriage therapists? Great. How about nurses? Oh, we have a lot of nurses too. Great. Any primary care providers? See a couple of those hands. They're kind of going up in the back a little bit. Psychiatrists. Okay, we have psychiatry presenting, but not so much in the audience. That's good to know. Any government officials here with us today? Medicaid or other insurance company officials want to raise their hands? Okay, awesome, great. Well, like I said, I'm Liz. This is actually my boss, y'all. This is Chris. But we work closely together. So we're going to kind of tag team this presentation. I'm going to share a little bit. He'll share a little bit. We really would love for this to be a discussion more than a lecture. So if you have questions, if you have comments, just raise your hand. We have a microphone that we can bring around. But we'd love to have a conversation with you all for the next hour and a half. And I understand we are what is between you and lunch. So we are really going to try to end at 11:30 because I do not want to keep anybody from their food. So that's our time frame today. All right, so as I mentioned, we'll go through some integration and primary care models for behavioral health, collaborative care. We're going to talk about specifically our North Carolina AHEC scope of work, some of the things that we're doing in North Carolina to help practices understand what collaborative care is and then integrate the model in their practice settings. We also have some information about our implementation gap analysis. We'll talk a little bit about coding and billing. And then we would love to share our experiences and lessons learned and also hear yours. So that's really where that Q&A part is going to come in. Here's your objectives, kind of self-explanatory from the agenda. Okay, so let's spend a little bit of time on behavioral health integration in primary care. So Dr. Hobbs covered a lot of this. I don't know that we need to go too detailed here, but just as a reminder that SAMHSA defines integrated behavioral health as whole person care that focuses on overall health. It creates partnerships across all aspects of health. It's facilitated by a variety of clinical, structural, and financial arrangements and community supports that remove barriers between physical and behavioral health care. Whew, that's a long definition. But the main point that we wanted to say here is that integrated care is not intended to replace traditional mental health care. So the specialty care in our communities is still a very valuable resource. We certainly want our integrated practices to work in collaboration with the specialty care providers. So the main objectives for and outcomes for behavioral health integration: promoting overall health, closing those treatment gaps, enhancing access, reducing stigma. This is kind of an overview, like I said, of the earlier presentation today. Reducing risk of self-harm and suicide, increasing positive patient outcomes, patient satisfaction, improving clinical outcomes for clinicians, increasing their satisfaction, and promoting the long-term value. So this is another version of the integration levels. Again, Dr. Hobbs shared this. We really worked closely with her. And I will add, just as a little anecdote, I'm a Tar Heel, so for me to work after a Duke person, it's a little hard, but we're gonna get along today, just for this. It's all fun. So the different levels of integrated care, we have level 1 is minimal collaboration, all the way over, and it's kind of hard to see because it's light, but level 6 is your full collaboration, transformative care, integrated practice, right? So I think there was already some conversation around this. People were raising their hands. Level 1, you have a behavioral health person in your office. They're not really communicating with the other members of the team. They may be co-located down the hall, but you're not sharing records in the EMR. In the middle, you're starting to have those conversations. You're working together a little bit, but there's still some gaps in care. Level 6 is what we're really focusing on. So this is the fully transformative front office all the way to the back office. Everybody understands what the integrated care model looks like. They're able to talk to patients about it. You're all looking at the EHR. You're all sharing part in that care plan formation, and you're really working together as a team. So there are two kind of, I would say, most evidence-based, most popular models for the level 6 integrated full transformational practice change. And that is primary care behavioral health, PCBH. Anybody here doing PCBH in your office? I see a few hands. Okay, that's great. So there, the behavioral health provider is available as a consultant. They're kind of a generalist. They do a lot of like curbside, what I would call curbside consultations. So it's kind of the like, hey Liz, can you come with me to meet this patient? Here we go, okay? And then you're just like on, right? You're there with that patient, you're addressing their needs. It really mirrors the primary care pace. So you are, if your clinic is fast paced, seeing a lot of patients, so are you. There is that warm handoff for PCBH, and there's some brief interventions that are provided by a behavioral health provider, but it's really to improve health behaviors and preventative care. Collaborative care is what we're going to spend the most time talking about today. So in collaborative care, there is that registry-driven, measurement-based treatment to target, population health focused. You use your screening tools, so your PHQ-9, your GAD-7, your Vanderbilts, and you have a weekly psychiatric consultation between the behavioral health care manager and the psychiatric consultant. There's over 80 random, I think it's actually 90 now, keeps going up, but there's over 80 to 90 randomized clinical trials that are supporting the evidence base for collaborative care. All right, so show of hands again. I know we did this earlier, but who is actually implementing collaborative care in their practice currently? Okay, I see a few hands. So that's actually that's really good. So I won't probably spend too much time here because a lot of folks already seem to know about collaborative care, but just a reminder of the benefits. It really improves the quality measure performances for practices to meet their targeted population in terms of their chronic disease states, their transitions of care. It results in improved financial and quality cost performance. It gives patients and families the help they need in a setting that they're already familiar with. So it reduces that stigma, right? They don't have to go to another provider, see that car, have their car parked outside that their neighbors are recognizing. Dr. Hobbs talked about that earlier. It also frees up appointment access for other types of patient appointments, and Chris is going to talk about this a little bit more later. But the PCP, can fill those spaces on their schedule with other patients that they can then bill for those patients while a behavioral health care manager is hopefully billing the collaborative care codes for the behavioral health needs of that same patient, for that patient. It also reduces PCP and staff burnout, providing specialized resources to manage behavioral health needs of the patients. Some additional benefits, it really enhances your local practice brand. So we're going to talk about this more when we talk about what we're seeing across North Carolina. I think there's this healthy competition between practices where if one practice in a community is providing collaborative care, word of mouth travels and the other practices want to do it too, right? So they want to put that feather in their cap as well and have that service for their patients in their clinic also. Provides greater leverage with payers during contract negotiations by demonstrating the ability to provide comprehensive and evidence-based services. It attracts primary care residents. So I know we have some students here from social work, but anyone in your master's program or your undergraduate program, did you have exercises in integrated care? Did you learn about integrated care? I see some yeses and some nos. So I think it's like we're building that training for our workforce. It's still kind of new, but I know at UNC, when I was doing my master's in social work, we had 2 days where the social work students, the nursing students, the dental students, the medical residents, and the public health students, we all met together and we had a patient who was a mock patient for us. And so we all had to do our individual assessments and then work together as a whole person care team. And that has stuck with me. I won't tell you how many years later since I've graduated from my master's program. I'm not old, but oldish. That kind of care is the care that we're talking about, right? It's working across disciplines to really support that patient's whole person health needs. Siloed care is the thing of the past. Like, we really need to get into this integrated system so that we can really support patient outcomes. And if you have it at your practice and primary care residents are being trained in that, they're more interested in staying at your practice. It also helps Medicaid and managed care plans to move the needle on improving population health for both the physical and behavioral health realm by reducing overutilization of behavioral health services in costly settings, right? It's expensive to provide care. So if we can do it in an integrated setting, that reduces costs and improves the patient outcomes. Okay, so we talked, Dr. Hobbs had this up too. Who has seen this before? Who knows collaborative care? Okay, I would say maybe like 50% of the room. So I call this the COCM triangle. If you don't remember anything else today, just remember this dynamic of what collaborative care looks like. This is from the University of Washington Ames Center. They created this structure. And collaborative care really assists primary care clinicians to manage patients with mild to moderate behavioral health conditions. And it's to a point of remission with a specific treatment to target. So we'll get into that a little bit more when we talk about the registry and some of the ways the behavioral health care manager tracks patient outcomes. It's consisted of a patient-centered team that the patient is always in the center. The patient and family caregiver, which is not pictured here, would also be located in the middle of this triangle, if you will. You can see the PCP is at the top, the new position in collaborative care, which is the behavioral health care manager, and then the psychiatric consultant, and they're communicating through the registry. So the PCP maintains their established relationship with the patient. They are still quarterbacking the care for that patient. That doesn't change. They work in close collaboration with the behavioral health care manager and the psychiatric consultant. They still prescribe the medication. So the psychiatric consultant can make recommendations, but the scripts, the med orders, still come through the PCP in the collaborative care model. With the assistance of a psychiatric consultant, they can prescribe a wider range of medications, maybe medications that they didn't receive training on when they were in med school, they're not as familiar with. That's the benefit of having the psychiatric consultant. They also can look at some different behavioral health therapies with the behavioral health care manager giving input into the care plan for that patient. The PCP serves as the billing provider. So all the billing in the collaborative care code still falls under the PCP. And we'll talk more about that in regards to who can serve as a behavioral health care manager, because I think this is where we've seen some practices get a little bit confused because they think they have to hire a licensed person to do collaborative care because they kind of associate that licensed person with being able to bill. But in collaborative care, because it's under the PCP's MPI, in North Carolina at least, you can have a behavioral health care manager who's not licensed. So we'll talk a little bit more about that in a minute. All right, the behavioral health care manager, they support the treatment plan with the PCP. They coordinate the overall effort of the group. So they're really the backbone of the collaborative care model. They educate the patients on mild to moderate conditions. Anxiety, depression, ADHD are kind of the main evidence-based conditions for collaborative care, although it has been shown to be effective also for trauma, for bipolar disorder. So it's growing in its evidence base, but really when we're talking about collaborative care, we're looking mainly at mild to moderate depression, anxiety, and pediatric ADHD. The behavioral health care manager will provide brief behavioral interventions for those conditions, usually motivational interviewing, problem-solving treatment, behavioral activation. Cognitive behavioral therapy is something that they can do, but I will add, as I mentioned before, a BHCM doesn't have to be licensed. So you have to kind of watch which modalities require a licensure to deploy. We're seeing this in North Carolina with our behavioral health care managers who aren't licensed. They're kind of taking parts of models, like parts of cognitive behavioral therapy, parts of DBT, and they're using those in collaborative care. It gets a little bit of a slippery slope there because, again, you want to make sure that you're doing due diligence to what your credentials are. But it is possible in collaborative care that they can adapt some of those modalities to work in a collaborative care setting. They administer all of the rating scales and they track the treatment response in the registry. So they're putting in the PHQ-9 scores, the GAD-7 in that registry, and they're sharing that data weekly in a systematic caseload review with the psychiatric consultant. So they usually meet for an hour a week with the psychiatric consultant, and they talk about any new patients, any patients who aren't improving, or any patients that they feel like maybe need more escalated care. They need to be referred out to a specialty provider. They also communicate the resulting treatment recommendations back to the PCP. And as I mentioned, in North Carolina, this is how North Carolina Medicaid has set the definition of who can be a behavioral health care manager. So it can be a licensed behavioral health provider or an associate in A. It could be another designated, this is the biggest part right here, if I had the pointer, but I don't think I do. So the other designated and appropriately trained member of the care team who provides care management services and assessment of beneficiary needs. That other has been both helpful and challenging because it's casting a wider net, right? We know there's a behavioral health workforce shortage. So it's great that we are including other non-licensed individuals in the definition of who can be a behavioral health care manager. But we have seen that some of these folks who are coming in who haven't gone through some formalized training are at a loss. They don't know how to have a one-on-one session with a client. They don't understand confidentiality. They maybe have never documented in an EHR. So when we talk later about our training efforts, we are trying to meet our very diverse set of behavioral health care managers where they are in terms of their training needs. And some are kind of beginner, intermediate, and then expert. So think about that if you're thinking about training your behavioral health care managers, as it's not necessarily a one-size-fits-all. because of their different backgrounds that they can have for this role. Okay, moving on to the psychiatric consultant. As I mentioned, the psychiatric consultant reviews the collaborative care caseload weekly with the behavioral health care manager. They suggest the treatment plan modifications back to the PCP. There's direct communication between the psychiatric consultant and the behavioral health care manager, but they typically do not talk to the patients. So the psychiatric consultant is just that, they're a consultant. They're not a treating provider, so they're not meeting with that patient. It happens sometimes, it's very infrequent that they will meet with a patient. It's typically that they're meeting with the behavioral health care manager and communicating with the PCP. It can be either a psychiatrist or an APP trained in psychiatry or behavioral health, and they have to have full prescribing authority. And AIMS also recommends that the psychiatric consultant have credentials in the same state that the PCP is located in. So we've seen this with some of the telehealth third-party turnkey vendors who are implementing collaborative care. We want to make sure that the psychiatric consultant is credentialed in the state where they're supporting the patient population.
I'll just make one comment
Go
as
ahead,
well. Liz mentioned it's recommended for them to be credentialed in the state, but one of the things that we also remind PCPs is to check with your medical malpractice carrier, because what we found in the early rollout of this model, we had some telehealth vendors, and there's a lot of good ones out there, but they were using folks that were not credentialed in North Carolina. So there was a case where one carrier said, all those services you provided for the past 6 months, we are not insuring that if you ever get sued. So it's really important that they be credentialed in the state of Arkansas. So just want to pass that over.
Yep, thank you, Chris. I can get us back to where we were. The farther I walk away, the less it works. Anybody else notice that? Okay, there we go. All right, the registry. So AIMS has an incredible registry, their caseload tracker. It will track your PHQ-9 scores, GAD-7, Vanderbilt. There's a slew of evidence-based modalities that it'll track your screening scores. It'll also kind of flag if a patient has gotten worse in their scores, if their scores have gone up. It'll also notify you if they've gone a long time without an appointment. So it's a really great tool for a behavioral health care manager to use in collaboration with the psychiatric consultant, and the PCPs also have access to the registry. In North Carolina, we actually are working in conjunction with Community Care of North Carolina, and they collaborated with AIMS to create a registry for practices in North Carolina to use free of charge for up to 3 years, but we started like 2 years ago, so we're in our last year of it, but they're hoping they'll expand the free access. That registry is wonderful. That has all the bells and whistles. It does all the things. A registry doesn't have to be that, though. A registry can be something that is built in your EHR. It can be a spreadsheet. If you're really good at Excel and you want to build out a gigantic spreadsheet for your full-time caseload of 60 to 80 collaborative care patients, you can do that. There's no restrictions that say you have to use the AIMS caseload tracker. In North Carolina, because we have that free access, a lot of our clinics use it, but not everyone does. So it's really tracking, again, that measurement-based treatment to target. It's used as a tool to allow for step care, efficient use of resources, and then any needs to intensify treatment or potentially refer out to specialty care if needed. There we go. Okay, so mostly the target specialties and patients that are implementing collaborative care are advanced medical homes. In North Carolina, we have advanced medical home pluses. They are actually primary care clinics who are a tier 3, who also have behavioral health, and they have applied for certification in what's called our tailored care management program. I won't go into all the details because that's probably another presentation for another day, but in North Carolina, we have 4 tailored plans who work with severe persistent mental illness, IDD, severe substance use disorder, and traumatic brain injury. And so we have a lot of clinics who work in that space as well for tailored care management. They also could do collaborative care. So we have a lot of like this happening in North Carolina where there's overlapping services for different populations of behavioral health providers. But mostly the primary care providers who are implementing collaborative care are pediatric offices. They were the first ones to, I think, show interest in the model in North Carolina. So we have a lot of pediatric offices family medicine, FQHCs, rural healthcare centers, internal med, some local health departments that have primary care. They're also eligible for implementing collaborative care. And the model is mostly effective for ages 8 and up. There has been some use for children younger than 8, but it's really tricky. I mean, I don't know, I have an 8-year-old at my house. There's no way. Like, there's no way that he could sit through a 30-minute session and honestly share his feelings with a counselor. Some 8-year-olds can. My guy, not so much. So beneficiaries 8 and up is who we're really talking about here. Again, mild to moderate, anxiety, depression, pediatric ADHD. There are some other mild to moderate conditions, bipolar. When I say trauma, it's really more like a crisis response. You know, collaborative care is not supposed to be psychotherapy. So it's not your 50-minute sessions where you're unpacking, you know, historical trauma and working for years on cognitive behavioral therapy or trauma narrative or what have you. It's brief. It's brief interventions. The episode of care is typically 6 to 8 months. So it's really fast. You're seeing patients maybe 30 minutes every other week. And y'all shout out if you're doing something different, because I saw some hands for who's doing collaborative care. But it's really meant to be a modification of their behavior over a short episode of care. So not years and years of psychotherapy. So the brief treatment, like I mentioned, psychiatric med management with a psychiatric consultant, and then that treatment to target screening and symptom monitoring. All right, Chris, you want to take it from here? This kind of went through. Well, I'll do this last slide. Okay, so for collaborative care, you really want to look at who's appropriate and who's not. And this is where having a seasoned behavioral health care manager to help risk stratify who is appropriate for the model and who would need other specialty care can be so important. Because your providers are going to get really excited. Your PCPs, they're going to love that they have a behavioral health person in their office, right? Or on their staff doing telehealth, whatever it might be. And what we're seeing in North Carolina is once that behavioral health person is there, they're like, here's all our behavioral health, right? So have fun. Thank you. You're amazing. Bye. I'm going to be over here seeing other patients now. If you need me, just, you know, holler. That's not what we want, because that burns out behavioral health care managers really quick. And it's also not the best way to provide patient care, right? Because they need designated care at the level that really is going to support them the most. So it's important for the behavioral health care manager, and this is hard, I'm saying this and I'm like, man, this sounds so easy when you say it, to advocate their role on the team. To say, this is what I was hired to do. I'm hired to do brief interventions for mild to moderate. I'm not hired to see schizophrenia, severe persistent mental illness, IDD. If you want me to do that, and I'm appropriately licensed and trained to do that, we can have that conversation. But if I'm doing collaborative care and I got a caseload of 60 to 80, I'm going to be turning them over really fast, right? I'm not probably going to also be able to have enough time in my day to manage high acuity patients as well. And that is really hard, especially if you were the only behavioral health person at that clinic. To have that voice and to advocate your role is really challenging. So we're doing a lot of work with teams and also behavioral health care managers in North Carolina to get those conversations happening so that the referrals to collaborative care are appropriate for the model. So we're looking at PHQ-9s, typically 9 and above. We say just start there. Start with, you know, your PHQ-9s 9 and above, your GAD, same thing, 9 and above. See how many patients you have on your panel then. Have your BHCM work that panel. Try to bill monthly, see how the codes work out for you. And then maybe you can add on some other conditions, or you could look at people who have, you know, a different range of scores on your PHQ-9 or GAD. Suicidal ideation does come up. However, I would say that if someone has a history of suicidal attempt or ideation, I would recommend that they have a higher level of care if there is a resource for them, you know, to go to that level. Excuse me. If you have any concerns for psychosis, that would be a referral to a higher level of care. Autism sometimes is appropriate for collaborative care, but if they are on you know, the lower functioning end of the spectrum or have severe IDD, they may require additional significant support. So it could be best for that patient to refer them out. And if they have severe substance use disorder, that would be another recommendation to refer them. You're going to want to just hold this over there because it's not the side. Okay. All right, you want to take the codes?
You want to mention to the room how many patients should be on the BHCM's patient panel,
sorry,
and then
I
how
thought I had.
long they should be on the model.
Yeah, I thought I had, but if I didn't, I apologize. So a full caseload for collaborative care BHCM typically is 60 to 80 patients. And again, you're seeing them for a shorter period of time. So the episode of care is usually 6 to 8 months. So you're turning that caseload over quick. They can come back after they've completed their relapse prevention plan. You actually start relapse prevention planning at the first session, which is kind of weird. You do your assessment and this is how we're gonna graduate you out of collaborative care at the first session so that they know, the patient knows, this is not a long-term relationship. Like, I'm gonna see you for a little while and you can come back, but the goal is to help you with those behavioral modifications so that you can support your mild to moderate condition independently.
These right here, we're not going to bore you with the details and make this a coding workshop. However, this does help you get paid. And as you can see here, these are time-based codes. It was mentioned earlier that these are not codes you bill after each visit, like a fee-for-service model. These are codes you bill once a month, and you track your time in the data registry with your BHCM tracking the minutes associated with direct and indirect patient care. But at a certain interval of the month, you basically tally up the minutes, and then that will tell you what CPT code you can bill the payers. And you see here in North Carolina, we have the Medicaid rates. What North Carolina decided to do several years ago, we were fortunate we had a secretary who also had a behavioral health background and had a significant concern about what's been happening in all of our communities since COVID-19 with rates of behavioral health illness going up dramatically. And so he said, instead of paying 100% of the Medicare 2022 fee schedule, let's pay 120%. And what he challenged all the private commercial payers to do was to get in line. And they all said, yeah, sign us up, we'll do this. So it's created a model where it's an all-payer solution in our state. We're very fortunate to have this because the providers don't want to have to think, oh, this patient has Blue Cross Blue Shield, they're good for this model. This patient has Medicaid, they're not good for this model. This patient has Medicare, they're good for this model. We didn't want to deal with that. So all these rates that you see here were put in place to make this model financially sustainable. You're not going to make a lot of money. You're not going to bring in, loads of revenue into the practice, but you're going to cover your basic costs associated with the program. And I'm going to show you a pro forma that we developed. There's other pro formas out there, but we kept ours simple. But as you can see here, it escalates based on the amount of minutes that you're spending with each patient. Now, rural health clinics and federally qualified health centers have a little bit of a difference. They use a G code, a G0512. And what we ran into, they wouldn't embrace the model because they said, until you get us paid on that G code, we can't do this. And we advocated to Medicaid. They went to CMS, got approval, put it in writing. They always go by what's in writing. They got a fee for that, and we're good. So, Liz, I don't know if you have anything to comment related to this.
I think you covered it.
Okay.
The G2214, now I'm back, yeah. The G2214 code is used typically at the very end of a month. So if you don't have time in the month to do the 99492, the 70-minute code, you'll use that G2214. And that has really helped our behavioral health care managers who feel like, I got 2 days in this month, how am I gonna see this patient? Well, if you are still doing care services, if you're arranging care, if you're resource finding, you can claim that G2214 and still get paid for that care coordination time. And that's really added to
Right.
the financial incentive.
Right. So a lot of times practices will have this idea. Usually it's a PCP in the office, sometimes an administrator, but usually a PCP champion who goes, I want to do this in our practice. But it takes a lot of planning. And the PCP has to have a conversation with his or her physician and APP team, the advanced practice provider team, and say, how many of you want to do this? Y'all want me to start with me or maybe a few others down the hall? But how many of us are going to do this? And then we're work with the practice administrator. You cannot do this without the practice manager in the primary care office. You've got to get their buy-in, and they're constantly putting out fires all day long. So the first reaction is probably going to be, let's talk about it 6 months from now. But if you get them on board with the PCP, you've got a really good chance to make this model work. And what you're going to want to do is the practice is going to want to determine what percentage and what types of patients are going to be appropriate for COC. And so typically practices will run a report out of their EHR based on diagnoses. Liz mentioned earlier the mild to moderate diagnoses of anxiety and depression and pediatric AD, and just go down the list and see which patients would be appropriate and do we have enough patients to make a go of this. And then you're going to want to do a cost-benefit analysis or a pro forma, and I'll go over this in a minute. This is a tool that you all can also use. And you're also going to want to have conversations with all the payers. Look at your contracts for those CPT codes. See what the fee schedule is. Make sure that those fees are in line to cover your cost. If you see that there's some CPT codes missing for Aetna or Blue Cross or Cigna or United or whatever, follow up with them to get that code included. And what we found in North Carolina is pretty much most of the commercial payers are covering these. If it's not in the contract, though, they're not going to pay. So you have to get your contracts updated. Figure out who's going to be your psychiatric consultant. And that's really important. Sometimes you may use a telehealth model, which is great, or you may partner with a local psychiatric consultant who understands the collaborative care model, and that's really important. They really need to understand the collaborative care model. And there are trainings through the American Psychiatry Association. There are trainings through our North Carolina AHAC. We have these available at no charge, so there's nothing to keep you from taking those courses. But they need to be trained. And also, sometimes university systems are a good partner. Maybe the University of Arkansas system would be a good partner here. I'm not sure what their capabilities are, but back home, we use Duke and Carolina. And they actually work together. It's unlike basketball. They actually do work together. And we've been very blessed with that resource. So they will offer to contract with practices. And so what practices will have to do normally is sit down with the contract. We have a contract template that was developed by the North Carolina Academy of Family Physicians in partnership with the North Carolina Psychiatric Association, a boilerplate template of a contract. That's available if you're interested as well. And basically you're contracting, as Liz said, for an hour, 2 hours a week at an hourly rate. And the model is sustainable, paying that psychiatric consultant. And typically the rates are around $200 to $300 an hour. That's typically, if you go any higher than that, you need to negotiate. Behavioral health care manager, you can directly employ them if you're a primary care practice. You can contract with them. You can have them work on site. You can have them work hybrid. You can have them work virtual. You can work with a telehealth vendor. Liz, what would you say the going salaries in North Carolina are for a behavioral health care manager, roughly?
It's usually like 65,000.
Okay.
I've seen some as high as 70,000 for licensed folks.
It varies state to state. It varies rural versus urban, but in general, that would be the range. And then a registry tracking solution, Liz mentioned, you can use a spreadsheet, certainly. If you've got Excel skills, if you're practicing, you don't, there's always an intern who can help, maybe your kids who can help you put it together, or there's YouTube videos that will show you how to do it. But we're very fortunate that we partner with Ames and Community Care of North Carolina to have a registry solution for us. And in North Carolina Medicaid is paying for the registry for the first several years. I think we've got another year or two left on the contract, but the intent is not for it to be a forever thing. The intent is to get practices started. And typically the registry cost, I think, per year, if you go with the Ames, I want to say it's maybe around, yeah, it varies around $700, $800 a month or something like that. But that's something that is very important. A good registry is really helpful, because not only can you keep track of your minutes so that you can bill out appropriate, but it allows you to track how they're doing on those screening scores over time, and you can see the color codes change. You can run reports on your patients, and you can see if they're moving along the continuum so that eventually they graduate from the model. So it's really important to have something that works for your BHCM, your psychiatric consultant, and your PCP to look at together. You can potentially approach your clinically integrated network or your accountable care organization for financial support. Don't count on it, but it can happen. We've seen examples of that. And then use a checklist to get yourself and implement the model. And we've actually developed a checklist, and that's available to you if you'd like to use. It's all publicly available material. So this right here is the implementation plan or checklist that I mentioned earlier. You'll notice there are various tabs. There's a checklist to make sure your organizational commitment is there. There's a checklist to evaluate your data, and so on. Practices use this to make sure they stay on track and to get the program up and running, but also to make sure that it's set up to succeed and not fail. In North Carolina, we have, through our AHEC system, 42 practice support coaches spread across 9 regional AHEC centers. And they go on site or work virtually with these practices, helping them go through the checklist. You don't need a coach to do that, but a lot of practices like to have a little hand-holding and to work them through the process, consider what adjustments to workflows that may need to occur. That's really important. I always thought this would be a pretty simple model to implement, and then when I hear the stories where, okay, well, how do we handle registration? How are we going to do this through our EHR? How are we going to document our work? When does the BHCM pass along the minutes to the biller coder or to the billing company to send the bill out the door? What's the workflow for the PCP to do the warm handoff to the behavioral health care manager if you're doing a warm handoff? It's those kinds of things, and every practice is a little different in their expectations based on the way their facility is set up, how much square footage they have, what the personalities are like, what staff they particularly have, and so on. So,
Chris, can I highlight something before you move on? And I was going to add, the other big question we hear is who gets consent? And in collaborative care, it usually is recommended that the PCP gets consent from the patient. It can be verbal, but it just needs to be documented in the EHR, so then that warm handoff to the BHCM can happen, and then the billing, in case it gets audited, that consent is in the EHR. One really big thing I wanted to highlight about our implementation plan, and coaches worked with practices to develop this in North Carolina, so this had feedback from lots of different practices. See this red here? It's kind of small, but it says training on COCM should be completed prior to moving forward with the remainder of the organizational commitment list. When you talk about collaborative care, you will hear people go, oh yeah, I know what collaborative care is. That's all of us working together in an integrated system. Got it, cool. They don't necessarily know that there is a model with specific components and roles and responsibilities. So before we go any farther on this implementation plan with practices, we make sure that they are completing the training. We have 42 modules now, but we just make them take the first 3. They're an hour each, they're free. And it talks about what the model is, how billing works, the roles of everyone involved. So I just wanted to highlight that.
That's a good point. And these are just some other components of the checklist. And so you can see here we've got some tabs with the actual implementation, the post-go live, sustainability, and the annual review. It's really important to make sure that the practice staff are paying very close attention as they ramp up, but not just put this on autopilot, to continuously look for areas of improvement or things that need to be fixed, because there will be things to fix along the way, just as anything in life that you're trying to operate in a practice. We developed a very simple pro forma, and so you can see here we just put the CPT codes in here. You've got your payer, what they pay, and these are all hypothetical numbers, okay? But how many visits you expect based on your payer mix and based on the patients you've identified out of your EHR, what that monthly revenue looks like and what the annual revenue will be. And then you can see here in this scenario, this practice has $106,000 annual revenue, and the expenses, this is what it's going to cost for the behavioral health care manager, LCSW, the benefits, the psychiatric consultant that you're going to contract with, and any incidental expenses. I don't know if you're paying for their cell phone or you're paying for their mileage or whatever. But you can see here it tabulates the expenses, and you got a nice little profit. Now, the one thing to consider is it generally takes 3 to 6 months of ramp up to break even. So sometimes practices will go, oh, well then I'm going to lose money for the first 3 to 6 months. Perhaps, but you're going to save money in the long run. And I'm going to tell you why, because this spreadsheet only looks at the direct revenue and the direct expenses based on a fee-for-service model that is time-based. And I'll go into what I'm trying to articulate here. So I mentioned here, these are some benefits that we have found with the program, or Liz did, and we talked about the reimbursement. In North Carolina, we have 5 Medicaid managed care plans. Maybe there'll be more, but there's 5 Medicaid managed cares because we have privatized Medicaid in North Carolina, kind of like Medicare Advantage with Medicare. It's kind of like that. It's the world we live in. So, all the practices cover those, all the health plans cover that 120% of the 2022 Medicare rate. So notice 2022, not 2023, 2024, 2022. That's important. And so the other thing is North Carolina AHEC is a state agency. There's almost an AHEC in every state of the country formed in the early 1970s. In our North Carolina AHEC, we have 42 coaches, so our state agency has partnered with Medicaid to provide coaching support. And we talked about all the different things that we're helping practices with, but AHEC also has educational courses. We have, 40 courses that are out there with educational credits provided that are available to psychiatric consultants and behavioral health care managers, practice managers, addressing every nuanced topic about the collaborative care model you can think of. And I'm sure we haven't thought of everything, but we have a lot of courses out there. But we also host learning collaboratives. Once a month, we have a presentation from a speaker, and then we open it up for discussion. And Liz also has a behavioral health care manager support group, peer group, once a month where they get on the call.
When you say support group, it sounds like we're doing therapy on each other, and we're not. We're supporting each other, but we're talking about lessons learned. We're talking about some of the things I mentioned before about if you're the only behavioral health care manager in a primary care clinic, how isolating that can be, how can you advocate your role, that kind of thing.
And we mentioned the registry. So North Carolina Medicaid is covering the registry. We have psychiatric consulting, and we use an organization called NCPAL. And they work also with the Psychiatric Association, but North Carolina Medicaid, to help get the program up and running, said, NC PAL, would you provide the psychiatric consulting support for up to 10 primary care practices that take care of pediatric patients? And we will pay the bill. So they're doing that. And that NC PAL organization is made up of Duke and UNC psychiatric consultants in the pediatrics. And they're working on a model where they are going to open it up to even more practices, but at a contracted rate, and to keep those relationships going. We have behavioral health care manager outreach. So North Carolina AHEC conducts an annual on-site summit for BHCMs to get together and learn from subject matter experts and learn things from each other. And I mentioned the peer group as well that we have, but AHEC also coordinates outreach and BHCM workforce recruitment in partnership with several UNC system universities. So Liz, you want to talk about that just for a moment?
I keep turning this off so we don't
Because
get
we get the
feedback.
feedback, yeah.
So yeah, we're working actually with 8 different universities in North Carolina, mostly schools of social work, but some of them also have counseling programs. They're all BWET grant recipients through HRSA, so it's the Behavioral Health Workforce Education and Training. Some of y'all might be familiar with that. And they are collaborating with AHEC to post job opportunities for behavioral health care managers when a practice is looking to hire. They post those job opportunities on their alumni listservs, on their social media pages at no charge to the practice. And it's a great way to bring, a potential workforce to a job where otherwise they might not have even known, to look for that position. And we've had a couple BHCMs hired already, and we've only had this relationship less than a year with these 9 schools. I'm trying to get them to incorporate some more collaborative care education in their curriculums, but man, it is hard to change a university syllabus. Wow, talk about taking an act of Congress to make that change. But I think that's the direction that we're trying to move in, is to get more education on collaborative care to those bachelor's and master's programs.
Well, we also have a statewide consortium that gets together virtually every month. And North Carolina Medicaid and Community Care of North Carolina lead that consortium meeting. But it includes AHEC, the North Carolina Academy of Family Physicians, the North Carolina Pediatric Society, the Medical Society, NC PAL, the Psychiatric Association, the Community Health Center Association, North Carolina Office of Rural Health, and every one of the Medicaid managed care plans. And I think we also actually have some of the commercial planned CMOs on there as well. But during that call, we track progress that we're making in our state with the collaborative care model. We talk about opportunities or barriers that are going on and what can be done to fix those. So it's really a multidisciplinary, high-level meeting of all these folks that are key to making the ecosystem of collaborative care work in our state. And it's a nice thing that we have, because the GO 512 code that I mentioned, we brought it up. Our coaches were like, they're not going to embrace, FQHCs are not going to embrace collaborative care if we don't get this code paid for. We brought it up in that consortium meeting. They talked about it, and we got it fixed. It took a couple of months, but we got it fixed. So that's been a nice resource we've had in our state. And recently, there's a new project with the capacity building funds. So North Carolina Medicaid, through the legislature, got $5 million to distribute to primary care practices that are interested in getting this model up and running. This is the seed money, if you will. So they're providing the free registry, coaching support, trainings, up to 10 slots for free psychiatric consulting support, but they're also giving capacity building funds. And I believe the model is, it's right here. They're awarding up to $50,000 per primary care site. And a multi-site primary care organization can get 3 of those $50,000 per site. So you can get up to 150. But then there's 30,000 for practices that have already adopted the model but want to expand, and 20,000 per site for practices that plan to newly adopt the model using a telehealth vendor. So there's some criteria around it. You have to accept Medicaid. We started first with counties that were lower on the socioeconomic scale and moving outward on that. So that's been really exciting. So to date, a couple of years ago, we had 0 or 1 practice that we were working with in the collaborative care model, and now we've got up to 60 practices, and that's not including the individual sites, but 60 practices that are up and running with the collaborative care model. A couple of health systems, Duke and UNC, have implemented the collaborative care model, and I think by the end of this calendar year, they will be up and running across all of their sites in the state. And we're working with Advocate, which is out of Charlotte, and Novant, which are some health systems in our state, to get them up and running. But we're seeing growing adoption. It really started in the pediatric realm, pediatric sites, and then family medicine, and now we're seeing FQHCs, and I think we're gonna see some rural health clinics pick it up as well. Internal medicine's been a little slower. We do have 1 or 2 OBGYN practices. Prenatal, postpartum depression and anxiety, OBGYN providers are seeing a need there. So we're hoping that it will expand with OBGYN as well. And then we're also, although it's rare, but we're starting to see some interest by specialists, gastroenterologists, endocrinologists, cardiologists, implement it in their practice as well. So I wanted to go a little bit, I mentioned earlier about the direct revenue and expenses. Another consideration to think about is primary care practices operate mostly in the fee-for-service realm, but they do have a growing percentage of their revenue tied to value-based metrics from payers. They may be an accountable care organization or a clinically integrated network that negotiates those contracts on their behalf, but they also can negotiate those contracts directly with the big payers like Blue Cross, Medicare Advantage plans, Aetna, United, and so forth. But they're usually held to quality measures that are associated with hospital admissions and readmissions, emergency room admissions and readmissions, total cost of care. They're also held accountable for diabetes screenings and management, hypertension, depression screenings and follow-up. They're being held accountable for quality measures associated with chronic physical disease. You can only move the needle so far as a practice just focusing on everything below the neck. There are patients out there, if they're suffering from anxiety or depression, they're going to be hard to move the needle in things like diabetes, hypertension, keeping them out of the ER or the hospital, or maybe not taking their medicines, maybe not eating right, maybe not exercising the way that the primary care provider would like them to if you're not moving the needle on these behavioral health diagnoses. So the PCPs are going, I'm going to focus not only on the patients with anxiety and depression, but I'm going to also look at what their other chronic ailments are, and I'm going to monitor over time. And what they're finding, if they're doing it correctly, is they're moving that needle. So the patients are getting better, but the total cost of care is going down. The patients aren't ending up in the emergency room or in the hospital, not just for the behavioral health issues, but for their other issues. You've got patients with cardiovascular problems, stroke, diabetes. They're less likely to go to the ER or the hospital when they're getting the care. Also, we talk about suicide. These patients, this is not a model to treat suicide, okay? However, most suicide issues are not something that just turns on overnight. It's a slow, gradual burn where it just constantly heats up until they get to a breaking point. And if you get these kids or the adults treated early, they're less likely to be at that stage, taking up a bed in the hospital. I'm sure at the University of Arkansas, maybe this hospital here usually have the beds completely full, where their care access in these beds is very, very important, and you don't want to tie it up for patients that could have been taken better care of in their primary care office. The other thing is primary care offices. Primary care providers and nurses and staff and certified medical assistants and so on are dealing with a lot of burnout. They're stressed to the max, but maxed out with administrative burden by insurance companies and payers and just taking care of patients that When they have a model like this in place, they feel like they're taking better care of their patients. The provider is sitting in a 10 by 10 room with no windows. Primary care providers, typically 30, 40, 50% of the patients they see have problems with depression or anxiety. And they go, you're in here for this. Oh, doctor, I got one more thing to tell you. And then they take their hand off the doorknob and sit back down and looking at their watch thinking I've only got 10 to 15 minutes with this patient, and now they want to talk to me about their behavioral health concerns, but I've got nobody to refer to. The next available appointment for a psychiatrist is months and months and months out. Based on their insurance, the psychiatrist may not take them. Behavioral health providers that are in the community, good people, but they don't take all insurances. The patient, if I refer them out, will they ever get the care? Are they going to have trouble with transportation or the ability to pay their bill? But what if I can give them the care right here in this office? The patient's more likely to seek that care out and hopefully get better. And so that's the nice advantage about this collaborative care model. And also, when the provider is able to make the warm handoff to the behavioral health care manager, that provider can all of a sudden see 3 or 4 more patients in their day. How many of you try to get an appointment with the primary care provider and can't get an appointment? Can you raise your hands? How many of you have trouble finding a primary care provider? See, a lot of hands. If they've got this model in place, they're more likely to be able to say, I can take 2 new patient visits today. Or I can get that patient that called this morning in so that they don't have to end up in the urgent care center or the emergency room because they said I wasn't open or I wouldn't see them. So there's a lot of transferable benefit that this model has that appeals to primary care providers, practice managers, and their staff. And it's really important for provider retention. And you've got more and more providers coming out of residency now. You know, primary care providers, when you remember when we I don't know how many of you remember when we were on paper charts, but going to electronic health records was a big deal. If you didn't have an electronic health record, you're not going to get new providers to sign up and work with you as a practice. Well, this is becoming something, a general expectation. This needs to be in place. And it's hard because behavioral health care managers are not easy to find. So when you do find them, treat them really well, hear their voices, make them part of the team, and they'll stay longer. But we have found that not every office is able to recruit or retain a person on site or virtually to do this work. And so over the past year, we have worked with offices to implement a telehealth model. We also have, we just a couple of weeks ago developed, Liz did, a crosswalk of all the telehealth vendors that we know of that have come and reached out to us and say we would love to work with these practices, and we have them, you know, attest to what are their features of their model, and we share that with practices so that if they're looking for a telehealth model, they can explore that. So there's a lot of opportunity in this space, and we're just blessed in our state to have the full support of North Carolina Medicaid and some really good partners in this space. And we anticipate it will continue to increase in terms of primary care provider participation. We're at 60 sites. It's a 100% increase since last year. I would love it to be 120 in another year. But so there's a lot of possibilities for your state as well. I know some in this audience are already doing collaborative care. But if you are interested in learning more about the resources we have, both the courses, the learning collaboratives, all these tools we develop, we do not charge for this. So this is free of charge. You can access it off our website, ncahec.net. So I'm going to stop there. As you can tell, I've been drinking the Kool-Aid on this. So. But I just can relate because Liz isn't a behavioral health professional, but I used to manage practices for a very long time, and we were always so frustrated that we didn't have a resource that was easily accessible for our patients, especially our children. And seeing this model in play just gives us a lot of hope. So anyways, I'll stop there and open up for questions.
So we know you're tired, we know you're hungry. We do have a few more minutes of your time. If we let you go like 5 to 10 early, can you just ask a few questions? Please, just humor us. Great, we have one. All right, we need our microphone. Can you be our microphone runner? He signed up for this. I didn't just volunteer him. Can you take it over to that side? It's coming.
Is it possible to make a collaborative care model sustainable when you have a high number of uninsured clients or patients at your primary care practice? Or like, is it possible to make this model sustainable?
That is a wonderful question. So I'm going to answer first and foremost with my social work answer, which is it depends, right? I think to Chris's point about collaborative care freeing up other appointment times, it depends on your patient mix. But if you have enough patients that qualify for the model and then also you're accepting enough new patients, I could see where it could be sustainable. But I know Chris has more to say on this, so I'm going to let him.
No, it's a great question. I would love to tell you yes, but it's really hard. What we have seen is primary care providers who will agree to take so many uninsured patients into their model, but first try to get these uninsured patients onto Medicaid and get that first if you know Medicaid will cover the model. That is all I can suggest to you. We've seen some practices that will not agree to see uninsured patients in the model. It's really unfortunate, but that's I don't think the model really is sustainable. Now, if you're able to get some grant funds, and there are a lot of philanthropic organizations around that may be interested in providing you with some funds to cover some of those costs, maybe even some state agency programs that can provide you with that relief. But unfortunately, unless you have those resources, it's going to be very hard to take care of uninsured patients in the model.
Yeah, because I think about our patients who are uninsured and don't have the ability to get Medicaid for whatever reason it is. And like a lot of times they don't have access to other health care, right? So like you can't get them into behavioral health. They can only really get into primary care if you're in a place where primary care can cover that. And so this is such a need, but it's like not accessible to everyone. So it just seems like there's like some inequity. But I would love to see how it would be able to be implemented in a place where there is such high numbers of uninsured.
Well, we've gotten some interest. No one's yet, I don't think, has fully embraced it yet, but we've gotten some interest from some free and charitable clinics in our state that have approached us about doing something in this model, but they're looking to get some philanthropy support or hospital system support that will cover their costs, because the hospitals can see an angle here. They're like, well, if we give you the money to cover this, then in exchange, these patients are less likely to use the emergency room or the hospital in return. So it just takes some folks that are willing to collaborate, be very forward-looking, and not completely look at the direct bottom line, but look more at like the indirect bottom line, just taking better care of patients. So it's a great question.
Thank you for that question. Anybody else? Anyone who's doing collaborative care have, I don't know, a lesson learned, a pearl of wisdom you could share with the group? All of a sudden, they're shy. Interesting. They were talkative before we gave our presentation. Here we go. Right up here. So who or what drove this in North Carolina? Was it the legislator, or where did it come from?
Well, I can't say for sure if it was a legislator or not. It's possible, but I know directly from what I know is that our Secretary of Health and Human Services, a gentleman named Cody Kensley, he has a behavioral health background. He's no longer with North Carolina Department of Health and Human Services because we have a new governor. But they have kept this program in place. But he was very adamant during COVID-19 working with Dr. Shannon Dowler at the time, who was our chief medical officer, a family physician, and they wanted to make a meaningful difference. And so they just got together and said, we're going to make this work in our budget. And what we've heard from them so far, the folks that succeeded them, is so far they have not seen their expenses go up. If, what they're seeing is and the data is still coming in, but what they are seeing is the more high-end claims costs associated with the patients that are on the collaborative care model are going down. And so they're actually saving money, and patients are getting the care they need on the physical health side, because these providers are now, as we mentioned earlier, able to see them a little bit quicker. So one of the things about the capacity building funds program, there's some criteria that practices have to agree to, but it's not too burdensome. It's just for a little while where they are required to submit some data reporting for North Carolina Medicaid to track and demonstrate that this program actually saves them money. And so it's not the end game to save money at Medicaid, but it certainly will help, because then they can do more to support the program. So that's what I know on the outside looking in, and it's possible that the legislature was involved. I will say this, the capacity building funds program, I know for sure, was appropriated by the legislature. In North Carolina, we have a House and Senate that are Republican-led and a Democratic governor. That's kind of the breakout of how we've been run for at least the past 8 or 9 years. So, but it's very much a bipartisan support for the program. And people in rural, urban areas, regardless of whatever political affiliation, they see this need out there in their communities and they want to do right. So many folks have kind of come on to this collaborative care model. There's still a lot of folks that don't know what it is, but for those who've heard about it and read about it, they like what they see, and they're hoping that it will be another tool in the toolbox. So.
Chris is exactly right. So Cody Kinsley, Dr. Shannon Dowler, really two individuals who learned about this model from Ames, saw that it could work in North Carolina with our mix of rural and urban areas, saw the need, obviously, post-COVID for behavioral health, mild to moderate conditions. And then they also said, okay, now we want this agency, this agency, this agency, and this agency, who were kind of out doing all their own separate things, to come work together. And we'll give you a little bit of money, but we're going to call you the Behavioral Health Consortium, and we want you to figure out how to do this. Cody and Shannon were both really great in that. Like, they would just charge you up, and then they would be like, all right, you got this. Go, right? And we did. We went. We had CCNC, Community Care North Carolina. We had AHEC. We had UNC and Duke. We had all the partners come together, and it's, I don't know, to me it was kind of a beautiful thing, because we broke out of sort of our siloed care to support breaking primary care and behavioral health out of their siloed care. So I think it's all about who you've got charging the mission, and just empowering different partners that they can do this, and that we can bring all of our resources together and support practices to make it work. And we meet with them, I mean, every week we have meetings with partners, still, and I don't think there's an end in sight. I think we're going to keep meeting on these various consortiums. We go to each other's meetings, we support each other's efforts. It's really, I don't know, it's been kind of a cool thing to have all of these partners who, we worked together a little bit before, but now I think we're really forming even stronger relationships through our support for practices in collaborative care.
Yeah. Okay.
All right.
Well, we'll let you
Any
eat.
other burning question? Oh, we got one in the back. Okay, last question, and then I promised y'all would go early. So last question. Okay. Correct. The psychiatric consultants do not usually meet with the patients, and the PCPs fill the med orders.
Can you hear me? Ooh, yeah.
Yes.
Okay, so why does the consultant have to have full prescriptive authority, and how do they define full prescriptive authority?
So I'm going to say malpractice is the reason. Could you hear her question? So she asked, why does the psychiatric consultant, if they're not seeing the patient, why do they have to have, and they're not writing the scripts for meds, the PCP is, why do they have to have full prescribing authority? And how do they define that?
Well, the PCP ultimately has the final say because it is the PCP's patient, but the medical malpractice carriers are very adamant about it because they feel that the BHCM that's working under the PCP, they're acting under their license, and if they're getting advice and feedback and modifications to what they're doing with the patient based on advice from the consultant, that the PCP's license and medical malpractice needs to account for the provider being in the state of North Carolina. So I can't speak for all medical malpractice companies, but the one in North Carolina is called Curi, C-U-R-I. They're pretty big. And so I would just encourage PCPs just to double check. We've also seen that the psychiatric consultant also wants to make sure that their malpractice insurance covers their work with the practice as well. It should, but there have been some cases where some psychiatric consultants have had some barriers getting their insurance to cover their work. More so where they have to pay some additional cost to get that additional coverage, although we haven't seen it too much, but there have been some cases of that. So I'm no expert at that, but I just make sure that the providers involved are double checking their licensure, the medical board, as well as their medical malpractice carrier to cover. They probably will be covered, but they just need to double check.
Yeah, I think it's a safety precaution more than anything, just to ensure that those who are making those medication recommendations have experience, education, certification to do so. I don't know that there's a specific definition of what full prescribing authority necessarily is. That's something I'm now curious to research, so thank you for your question. But I think, again, it is anyone who can prove that they have education, certification in psychiatric care at a level of being able to prescribe.
Okay, the reason I ask, because in Arkansas, when you're training as a nurse practitioner, you learn all about the medications. That's part of your curriculum. That doesn't necessarily guarantee you that you're going to have prescriptive authority down the road.
Okay.
Because some people will go to school and they'll get the license, but they won't get the prescriptive authority. And, you know, with the DEA regulations, I don't know about other states, but in our state, you can do some of the ADD meds, but you have to have special permission with your collaborative, and it just becomes very complicated. And I know with being a different state than Arkansas,
Yeah.
I didn't know how they handled it in North Carolina. So,
Yeah.
But thank you.
Thank you for that question. I would be happy to connect with you and learn more because I'm a social worker, so psychiatry is still, you know, it's a little bit my jam, but not totally my jam. So I'm still learning about the rules around prescribing. So yeah, thank you for that question. All right, thank you all so much for your time.
Thank you.
We really appreciate this opportunity.
Thank you
and
very much.
Enjoy lunch.